Today we will continue our discussion related to aspiration. So, just a second, please. So, this is the you can say the selling point of anesthetics. Whenever we start thinking about anesthesia, we start thinking about NPO, and we start thinking about aspiration risk. Sorry. Okay, so like if we just start that, how can we assess the risk for aspiration? What are the factors which will lead to increased risk of aspiration?
Sir, full stomach.
There are patient-related factors,
And
anesthesia-related factors, and surgery-related factors.
okay. Okay, so
And patient-related factors. Patient-related factors include the full stomach,
okay,
incomplete NPO, and intra-abdominal pathology like intestinal obstruction or inflammation, obesity, pregnancy, gastroparesis, like in diabetic patients.
okay. Autonomic neuropathy.
Yes, sir. Like autonomic neuropathy or patient taking opiate.
Okay. What else?
And then if there is a esophageal problem like symptomatic reflux, regurgitation.
Okay. If someone else was speaking, who was that person? Can you tell what was you telling? What were you telling? Some other person was speaking also. When Sumera started.
Sir, it was me.
Yes,
sir,
please.
it was me. It was I also have seen in absent gag reflexes secondary to bulbar palsy.
Okay, very good. Bulbar weakness. Okay. What else? Okay, actually, you know, we of course there will be certain factors which will lead to it, but generally, if we just try to think about it, that actually there is some volume in the stomach. Okay, so this is one thing. There will be some nature of the material in the stomach. Number two. Number three, there are bodyguards which are protecting the lower esophageal sphincter. Okay, this will be third thing. And like if you just think about them, you will lead to a number of things. And the other will be control mechanism, or you can say the control mechanism towards the airway. Okay, so airway, that thing, and then the airway reflexes. Okay, airway reflexes, whether present or not, because if patient has intact airway reflexes, patient can, there will be maybe laryngospasm and patient may cough out. Okay, but with that reference, if you think, then you will come to know that there will be any, for example, if the conscious level CNS problems, if patient's conscious level is not good, then like after all these mechanisms, this is the last protection. And if you don't have the conscious level with you, then aspiration cannot be prevented. Okay, and that will result in the entrance of the gastric material or intestinal material, to say, into the airway. Okay, so if you just think like that, you will come to know that you will find a number of things. Now, of course, what is the use, like anything which is blunting the airway reflexes, anything which is the bulbar muscles, the bulbar weakness, because this is the mechanism which is protecting the airway. Okay, even when we are talking, sorry, when we are eating, that the door is closed. Okay, so that nothing is going inside the no-go area. So that is the mechanism. So any cause related to muscle, like for example, we can have aspiration risk in conditions like myasthenia gravis. which has muscle weakness, or any condition which can lead to bulbar weakness. So one of them will be one of them will be this one, or any problem in which there is autonomic problem. So that will be leading to gastroparesis. Okay. So gastroparesis also in this one CRF. Okay. Gastroparesis in diabetic patient. Okay. Gastroparesis in pregnant patient. Okay. So there are so many, then you can think about it, that what will be the conditions in which there will be, like, so if patient has stress or trauma. Okay. So that's why if you want to count the NPO time, you will be counting the NPO time between the meal and the incidence. Like, for example, if after taking meal, after 4 hours accident occurred and now 6 hours have gone, so you will still consider this patient as full stomach. Okay. Because stress will reduce the gastric emptying and this thing. Okay. So this is the thing which you should be knowing. Then a few words about the anesthetic factors which can lead to or prevent anesthesia, this aspiration. So can anyone tell? Opioids is one of them, for example. What else?
Sir, anesthesia factor includes the inadequate depth of anesthesia,
Very
like
good.
it will lead to coughing and
Inadequate
or
anesthesia.
laryngospasm of the patient.
One thing. Other.
And during bag mask ventilation,
Very good.
there will
Bag.
be a dilatation of the stomach. And
This was what is the reason? What is the technical answer? That if you increase the pressure more than 15 to,
Positive
30
pressure
centimeter
ventilation.
water.
I'm sorry.
If you
15
increase the
centimeters
pressure more than 30 centimeter of water,
No, Sumera. 30? 30 is too much.
15 centimeters of water, sir.
I'm sorry.
15 centimeters of water.
Yes, it is maximum 15 to 20 maximum.
Yes, sir.
Yes, Dr.
Yes,
Lutfia, you were saying something?
Yes, I just would like to answer the question, but my colleague already answered it. Thank you
No
so
problem.
much.
Anything you want to add on?
No, thank you.
Okay. So this is Sumera. 30 is not 30. You are mixing it up with the it is around 28, that pressure which should be in the endotracheal cuff. Okay. That is for that thing.
okay.
Because before above that it will be pressing the vasculature. Okay. So you are mixing it up with that one. So back mask. What else? What else can prevent?
Sir, the ETT tube insufflation, if that is inadequate, that can also promote aspiration.
Like inappropriate site in that endotracheal tube without cuff with leak? Are you talking this thing?
Yes.
Without cuff. Okay. What else?
That leads to micro aspiration, if I'm not mistaken.
Okay, fine. What else? What about
Sir, low pressure,
Hmm?
low endotracheal tube pressure cuff.
Yes, that is also coming in the same thing.
So
Okay.
also, if you place an NG, the lower esophageal tone is decreased.
Very
That
good.
can also promote aspiration.
This one, NG, I was about to come to that thing, so we can discuss this thing, that if NG tube is there, okay, you will of course aspirate it. But if other than such acute abdominal conditions in which there is too much risk, otherwise putting an NG tube, you can aspirate the liquids, okay, but you cannot aspirate solid particles. So actually passing NG tube is always a controversial thing. So whenever you pass NG tube, you are damaging the defense mechanism by finishing the tone of lower esophageal sphincter. Okay, so that creates the problem. So this is one thing. Then another thing which is important. Just a second, let me think. what I was saying, it slipped out of my mind. Anyways, we will come back to it. So yes,
some physical positions as
yes,
lysopeny and Trendelenburg also increase the essence of caring aspiration.
yes, yes. Dr. Lutfia, what you are saying?
Yes, actually, I have one question. We
Yes.
just talking about the, I mean, natural stomach. So, what if the patient had history of gastrectomy or something like that to lose weight, or is it the same pressure as in case of positive pressure ventilation with the pressure over 20 centimeter of water will create inspiration and reflux, or
Just a second, please, Dr. Lutfia, can you unmute yourself again? Actually, there was so much noise coming, so I couldn't understand your question. Can you just repeat your question again, Dr. Lutfia?
okay, that's right. Okay. I'm just talking about that, if the patient had history of gastrectomy in case
Gastrectomy,
of,
okay.
in case of positive pressure ventilation. So I think bigger stomach can tolerate, a stronger pressure. But if the stomach smaller, it will be even with the lowest, with lowest pressure. Is it that right or not? Can
Yes.
create inspiration or
Yes,
something
you are
like that?
absolutely right. You are absolutely, actually, there is so much noise coming from your speaker, I think.
Oh,
So-
okay. Sorry, I'm outside. That's
Yeah,
why.
no problem. I think your point is absolutely valid. Your point is absolutely valid. And if, for example, if the mechanism is loss or stomach size is short, but actually, actually, it's a very good question. I will search. I will discuss this thing with some bariatric surgeon, because they can tell you that when they are removing it, after that, how, like, I think supposedly they will always have a chances of regurg, in my
Yeah.
opinion. So your point is absolutely valid. Okay. So actually,
Okay.
as Dr. Hisham or someone was telling about positioning. So actually, positioning is very important. Okay. So if, for example, if you have make a ramp position, this rapid airway management position. So actually, this is not only helping you in improving the respiratory parameters. Okay. It is also actually a protection against aspiration, because now the stomach content has to go against gravity. So significant pressure should be made before aspiration will occur. Okay. So
Okay.
this
Thank
is
you.
a sort of and similarly, if people sometimes mistakenly make head down position, if you are thinking that the patient has risk of aspiration, they initially made this head down position. So actually this is absolutely wrong, because if they will make the head down position to start with, actually they are predisposing the patient already by making the patient head down or Trendelenburg. Okay. So yes, if it occurs, you have to immediately do the head down. Okay. You will immediately do head down. You will make the patient a little lateral, and you will do the suctioning and everything. Okay. But this is a like you can say a point, so that you should be knowing that if you make a ramp position, this will also create a protection. Okay. So some other points that, for example, use of supraglottic. Okay, this is also a factor by which patient can have aspiration, because airway is not protected. Okay, so this is one thing. And then another thing is like if you want to prevent it, one way will be rapid sequence induction with required pressure. Okay. So do anyone know how much pressure we need to apply for this Salic maneuver?
So at least 3 newtons.
No, I'm afraid no. To start with, it is 10 Newton before loss of consciousness, and you have to increase it to 30 Newton after loss of consciousness. And then you will continue it till you confirm the endotracheal placement, bilateral, the cuff is inflated, and then you will remove this pressure. Okay. So 10 Newton is actually it's not an objective, it's a subjective. So exactly if you press the weight machine and the weight machine shows you 1 kg, it is 10 Newton. And if you press the weight machine and the weight machine is showing 3 kg, it is 30 Newton roughly. Okay. So in conscious patient, you will actually press it to the pressure till he the patient is able to tolerate it, and after that you will increase the pressure. Okay. Actually the issue is that required pressure practically is very difficult to apply, because you will not be doing it, the other person will be doing it, and sometimes it is very difficult to explain the assistant. Okay. So actually this question comes in the talks as well for OSCE exam, that how will you explain your assistant how much required how to put this Selic maneuver. Okay. So this is just by the way that you should be knowing about it, that you will explain. And actually sometime in short neck and obese patient, it is difficult to identify the landmarks. So that's why required pressure practically I have never never done in my 18 years career. I don't believe in it, because I think it is very difficult to make other person understand. But medical legally and in exam, never miss it, because you cannot defend. Even medical legally, you are not covered. If, for example, say pregnant patient, you don't do required pressure, and if aspiration occurs, you are not covered medical legally. Okay, so you have to do it. But practically, I'm telling you something. Practical experience is something else, and then the theoretical or medical legal stuff. Okay, so this is something you should be knowing. And if someone asks you what is modified rapid sequence induction, because you can, even at risk of aspiration, you can still do modified rapid sequence induction. Yes, please.
Sir, in modified rapid sequence induction, we can check.
So
We can do
in modified rapid
ventilation before giving the neuromuscular blocker, and even we can give the titratory doses of the drugs according to patient hemodynamics. And
You are using actually a high dose of 1.6, sorry, 1.2 milligram per kg of rocuronium. So you can mechanically ventilate with less than 15 pressure. Okay.
Okay.
So, but for that you should have Sugamedex. Without Sugamedex, you cannot do it. Okay. So this you can tell as a prevention. Okay. Some more things which are not written in all books. Actually, I have not done it. I'm not expert about it, but I will suggest all of you to learn how to calculate the gastric volume by ultrasound. Okay. If you can learn by some way, some of the people I have seen it doing it. So you can actually calculate with ultrasound how much is the gastric volume. So how much is usually critical? If you say that it is risk of aspiration, how much volume?
Sir, approximately 25 ml.
In adult, so it is around 0.4 to 0.5 ml per kg.
Right.
Okay, and what about pH? Less than 2.5.
It is less than 2.5.
Okay, and another important thing is that if there is fecal matter or solid particulate, that is more dangerous, because we will just come shortly. Now, who will tell what is difference between aspiration pneumonia and aspiration pneumonitis?
I think it's really classified according to the underlying cause of irritation of the airway.
Okay.
Pneumonitis, I think, include all irritant substances like chemicals, dust, bacteria, viral. but pneumonia related to viral and bacterial infection.
Yes, pneumonia will be resulting in the, usually if we are talking about with reference to aspiration, so it is usually because of fecal matter or bacterial. So this is chemical pneumonitis. For example, if you have acidic stomach content, okay. So this is difference between, because this will be resulting in loss of there will be problem in the gaseous exchange, there will be damage to the capillaries, there will be damage to alveoli, okay, and inflammatory mediators will be released in pneumonitis. And the third thing is actually with reference to fecal matter, I just was telling that if it can mechanically obstruct, if it is solid particles, even before that, if they are blocking the major airway, this will result in hypoxia immediately, okay, because it is physically obstructing the airway. So it will become like a foreign body actually at that time, okay, and it will result in atelectasis. So this concept of, so other that how to prevent, what will be the pharmacological things? Actually, there is a lot of debate between H2 receptor antagonist versus PPIs. Okay, so actually, because I didn't found a recent document about it. Okay, I couldn't find. So the latest which I found was 2017, and in that data they did not write much, because somebody just shared to me today that they have made they are not using ranitidine anymore because of some serious arrhythmias and complications. But I'm not sure about it. So anyone can correct me about it. Related to PPIs, and like PPIs like omeprazole or lansoprazole, it is being used. It will have no effect on the preformed acid. It will decrease the further acid production, PPI or these antacids. Okay, so this concept should be clear, that it will have no effect on the preformed acid which is there in the stomach. For that, you have to put non-particulate antacids, okay, 30 ml or something like that. Okay, I have never used in my life. I don't know how to use it. Any one of you have used it? How to give this? Sumera or anyone have you used this?
No, sir, I didn't choose.
I don't know how to use it, but it is documented. But the problem will be that the pH will be increased, but actually volume will also be increased. So actually it will lead to risk of aspiration. But of course, the pH is very important. If the pH is too low, that is a critical risk factor for the development of the respiratory lung response. Okay, so that's why it is documented. The other thing will be the use of this dopamine antagonist, metoclopramide, okay, domperidone, okay, and there is another one which is actually antipsychotic, I think, cisapride. This is also being used for increased gothic mortality. One antibiotic is being used. What is that antibiotic name? Which is used for gastric motility increasing?
Erythromycin.
Erythromycin. I don't remember the mechanism. Do anyone knows about it? How it increased the gastric motility? Anyways, I don't know about it. We are just using it, but I don't know about it. So these are a few points. And of course, NPO, proper NPO time, and avoidance of any factor which will lead to gastroparesis. These are all factors which will reduce the chances of aspiration. Okay, so now we will just have a look on the article.
Sir, a question.
Yes.
A prolonged bedridden patient, is he also subjected to?
I cannot hear you. Your voice is gone.
Sir, bedridden patient,
Bedridden
otherwise
patient.
conscious.
Bedridden
Yes.
patient.
Is
Yes.
he is he susceptible to gastric?
Unfortunately, your voice. But I understand your question. Yes, prolonged bedridden patient will have more risk. Okay. So these are some certain inhalation of oropharyngeal or gastric contents in the larynx and respiratory tract. This Mendelssohn syndrome was described as potential consequence of abolished airway reflexes under anesthesia and subsequent aspiration of gastric contents. Okay. Mendelssohn syndrome. Aspiration of solid material can cause hypoxia by physical obstruction, where aspiration of acidic gastric fluid can cause pneumonitis with the syndrome of progressive dyspnea, hypoxia, and all the differential diagnosis of this V's and consolidation. Okay. The people who are appearing in the British exam, you should be knowing this incidence, like British or Irish exam, because they make some questions on the basis of this national audit project reports. Okay. This is some physiology. I think it is lower esophageal sphincter tone. Yeah, just telling. First of all, we will look here. You see, full stomach emergency surgery, inadequate fasting time, gastrointestinal obstruction, delayed gastric emptying, systemic disease like diabetes, CRF, trauma, opioids, raised intracranial pressure. Yes, okay. This will also lead to vomiting and so previous gastrointestinal surgery. That will come to your point, Dr. Lutfia, what you were telling about this gastrectomy. Okay, this will also come here. Pregnancy, incompetent lower esophageal sphincter tone like hiatal hernia. Hiatal, yes, we did not mention this thing. Recurrent regurgitation, dyspepsia, previous upper GI surgery. Okay. They are repeating. Okay, so as I told you that protective airway reflexes will be protection. This upper esophageal sphincter tone is actually a prevention. Okay. Okay. So preoperative, what are the different strategies? Preoperative fasting, aspiration, prokinetic medication, and avoidance of GA, of course, regional anesthesia, antacids, H2 receptor antagonist, protein pump inhibitor. You should protect with tracheal intubation, and they have mentioned here second generation supraglottic airway device, but actually still because they can tolerate higher pressure, but still it is not wise to mention that because supraglottic airway devices still will have risk. Okay, so cricoid
But if
pressure.
a person has a ileostomy or colostomy, will there still be a risk of aspiration to that much extent?
Actually the pressure will be reduced. Okay, but if still there is because the gastric, even if there is ileostomy or there are the normal the intestinal and gastric fluid which are normally produced, so still there will be chance. Okay, though they have created a stoma, so the pressure will be relieved, the obstruction is relieved, but still there are chances. Okay, you will consider it in the same risk. Okay. So, okay. So guidelines to reduce the risk of aspiration, experience anesthesia assistance, intubate all emergency cases, appropriate cricoid pressure with muscle relaxant. Okay. Intubate seriously, consider intubation following delayed gastric emptying, pregnancy, opioids, diabetes, renal failure. Okay. Even I will consider, it's not mentioned here, even in babies. Actually, I have seen that a number of time this is actually practical advice. Everyone use supraglottic devices in pediatric patient, but if you have any doubt, because I have seen multiple times that even if the mother is telling, but still sometime baby has taken something. So like if it is not igel, because igel has better fixation. So the classical LMAs, they have problem in fixation. So you have to always, if you have even a small doubt, you should not use it. Okay. Blood aspiration will be relatively sterile. Okay. So it will have less effect than like dangerous things. Okay. Yeah, one thing we missed was post-tonsillectomy bleed. This is also one of the causes of risk of aspiration, especially airway bleeding. Okay. So I think we have covered a number of points. Yes. What will be the management, subsequent management? Is there any role of antibiotics, steroids, diuretics in aspiration pneumonia? They will ask you this question.
No, sir.
I'm sorry.
Sir, there is no role of antibiotics or plastics.
One by one. Dr. Banu, what you are selling, please?
I'm saying there is no role of antibiotics.
This is a very
Steroids.
hard. This is a very hard statement. There is role of antibiotic if there is fecal. That's what I think you are saying.
Sir, you said that the fecal would cause a physical obstruction.
No,
So
no, no,
how
not
will
necessarily.
antibiotics help in that?
No, 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 not necessarily. I said that it can cause. It can cause. Okay. But if
Yes, the fecal matter would contain bacteria. Obviously, that then it could cause a superimposed
Yes.
bacterial infection.
or you can send the cultures. Okay. That initially maybe antibiotic is not indicated, but later on, if because this is also a risk factor for further, because other bacteria can also colonize. So
No,
there
sir,
is some
then the proper statement should be that for a superimposed bacterial infection,
exactly.
yes, antibiotics would be. But for the aspiration itself, there's no point of giving
No point.
antibiotics.
Yes, Dr. Ahmed, what you are saying?
Yeah, but regarding the aspiration is settled as a type of our aspiration pneumonia. The word about aspiration pneumonia, it's a late complication or sequel of aspiration, and
Very good.
with high percentage of it to occurring. And it's subtitled as nosocomial infection or nosocomial pneumonia, which is not
Yes.
covered by wide spectrum antibiotic firstly, with subsequent descleration according to culture and sensitivity of the sputum.
Exactly. Exactly.
The aspiration itself is not treated by antibiotic, but the sequel of the aspiration, which is pneumonia, must be treated by antibiotic, and good coverage with antibiotic, empirical, and then continue according to culture and sensitivity.
Yes, absolutely fine. Absolutely fine. And similarly, there will be no apparent use of steroids, but rather it is said that if you use a steroid, it can increase the problems. Okay. And
Steroid, I think steroid is standard for ARDS. Is not
yes,
for if we developing ARDS with complete pictures of Berlin definition of ARDS, we think about using of steroid in this state. With covering also of antibiotic to it's a matter of balancing between the risk of fibrosis and progression of ARDS and hypoxia and fulmination of infection.
yes, thanks a lot. Actually, it is right now mentioned here about NAP4. So you can have a look on these recommendations because they can be asked in different ways, especially if you are appearing in any European exam. Okay. So these are simple things, not very complicated thing. I will share. Yes.
Sir, is there any susceptible duration that after aspiration that like 2 days or 3 days it is the susceptibility to develop aspiration pneumonia if the patient has aspirate some fecal matter or something like that?
Actually, I understand your question. Your voice is coming very less, but I understand your question. Actually, it will be depending on different patients. Okay, according to the immunological status of that patient, how good is his immunity, how is the response is occurring. Okay, the people who have low immunity, who have more chances of will have more chances of infection. The people like any patient who already has risk of infection, like diabetic patients, patient with CRF or any other, so that the response will be different as compared to if a young patient aspirate, maybe this response will be different. Okay, but usually it will take few hours.
Are there any exceptions, like if a patient is immunocompromised, we can prophylactically start antibiotic to prevent the risk of aspiration?
Yes.
Something.
Yeah, yes, you are your point again. Your point is valid. Okay, but I'm not sure about any specific guidelines to start antibiotics in immunocompromised patients. Okay, I think your logic is correct, but I'm saying the same thing, right? That if you have any patient with depressed immunity or any patient with any condition which is at risk, so there will be more chances. Okay, so Sumaira, I think we have covered. Anything we have missed?
So almost we have covered all the points.
I will
Like
suggest. I will.
there is one thing like
Mhm.
how to diagnose the aspiration. If patient is under anesthesia and he has aspirated, then how we can diagnose?
So there may be some like increased airway resistance, hypoxia can develop. Am I right? Then you can confirm it
Yes,
through
sir, right,
X-ray.
sir.
X-ray. Okay.
Sir, by ABGs as well.
ABGs,
Type
of
1
course, ABGs.
respiratory failure.
Yes, and then you can later on you can do bronchoscopy as well. Okay, because you will confirm with bronchoscopy. That's the thing which I forgot to tell you. You will do if
Sir,
the patient.
another question.
Yes.
Sir, that to diagnose aspiration, if there are food particles, any gastric contents within the mouth, so this is a patient who is at more risk of aspiration.
There is no guarantee, na? You cannot actually. That's why I tell you something that with the suction you cannot remove the solid particles. Am I right? It's not possible to remove them with the suction. So of course, if solid particles are in the mouth and patient has no reflexes, patient might have aspirated. Okay, so that's why you will later on the parameters you will go step by step. You can do ABGs, you can do chest X-ray, and then you can do bronchoscopy as well. Maybe the patient need lavage and suctioning directly under vision. Okay.
And sir, also on auscultation, there will be diffuse decreased air entry as well as
Decreased air
crepitations.
entry, wheezing, bronchospasm, like anything can occur. Okay. The things will be general. You will have to have the differential diagnosis like any other patient. Okay, so I think, if any one of you can confirm or even share later on, if you find any latest guidelines about use of this aspiration prophylaxis. Okay, the medications which are being used for aspiration prophylaxis, if you find any document, any one of you can just share it to me. I will share it to everyone. Okay, so I think it's enough for today. So tomorrow we will continue with some other topic. Actually, this is a topic which is everyone is dealing every day. So proper NPO time is very important. But remember one thing the other way, because if you are making the patient too much NPO, then it will still lead to post-operative nausea, vomiting. So you have to have a balance. You should have a balance. You will identify the patients at risk and you will anticipate. Okay. So I hope I just try to give you a concept, and any questions you can even ask later on. The purpose of this sessions is just to clear the concept. Rest of the things, of course, when you are reading a topic, you will find even more details. But I just try to tell you a concept which is important for you. Even if you are reading, it is said that eyes cannot see what mind does not know. Okay, eyes cannot see what mind does not know. So I am just trying to give you an eyes when you are looking at the books or articles or whatever source, you will be able to understand. Okay. So thank you very much. And inshallah, tomorrow we will have a session at the same time. I will share the topic which we will be doing. Okay. Bye bye. Thanks a lot, all of you, for your presence.